Hello, everyone. I'm Ed McCauley, President and Vice Chancellor of the University of Calgary. I see that we have a lot of people joining us today, which is absolutely fantastic. Welcome to our first ever virtual idea exchange. To begin, I'd like to take a moment to acknowledge that our university is located on the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. Over the next hour, we're going to explore the public health lessons that we're learning from COVID-19. We have three extraordinary speakers with us to share their insights today. And to get us started, I just want to very briefly set the context. Many of you have attended our Ideas Exchange before, so you know that this series is part of an ongoing series. It's an opportunity to showcase the latest research taking place at the University of Calgary, and it's a reminder that everything we do as a university ultimately ties back to the community. Your support means that we can lead critical research and new ideas, particularly in the times of crisis like the one we're in right now. This support takes many forms, from philanthropy to volunteer service and expertise, and all of this helps make a big difference. And just to give you a sense of this impact, we're tracking the research projects related to COVID-19 at the University of Calgary. The number is currently over 80 different projects, and it continues to grow day by day. University of Calgary researchers are looking at everything from rapid diagnostic toolkits that you can do at home, to new drug treatments, to the social impact of this pandemic on vulnerable groups. These scholars are tireless in their efforts, and they're joined by hundreds and hundreds of student volunteers. We've created two COVID-19 relief funds to support this research and our students. It's part of our larger Giving Day campaign that runs until May 22nd, and more details are available at ucalgary.ca/givingday. I encourage you to visit that site. Community support is also about the partnerships that we build to increase capacity in our healthcare system. Through strategic clinical networks, for example, we work closely with Alberta Health Services to translate knowledge from our researchers, embed our students in the healthcare settings, and support improved service delivery. These partnerships are a big part of the reason that our province has one of the highest testing rates per capita, and that we're able to provide quality medical care to Albertans. We achieve our best impact through these partnerships and the ongoing support and investment from the wider community in the work that we do. This includes the tremendous support towards the Energize campaign and programs that allow us to continue to strengthen our city and our province. We will announce the results of the Energize campaign at a future celebration on June 30th. But I can tell you now that the level of support and impact that it allows us to create is nothing short of inspiring. We are so grateful to be part of this community. On that note, I'm delighted to introduce our three speakers today. Each speaker will share a short presentation followed by time for questions from the audience. We'll first hear from Dr. John Connolly, Professor of Medicine at the Cummings School of Medicine. Next will be Dr. Bill Galley, Vice President Research at the University of Calgary and also a professor in the Cummings School of Medicine. And finally, we are delighted and honored to have Dr. Verna Yu, President and CEO of Alberta Health Services, joining us today. So to start us off, over to you, John.
Dr. McCauley. Just going to begin by giving you a little bit of background with respect to the virus itself. So I'm going to discuss how to understand some basic elements about SARS coronavirus 2 and its transmission. And you can see a stylized cartoon of the virus with its spike proteins sitting out there. And just to remind you that the virus is the SARS coronavirus 2. The disease that it causes is coronavirus disease, and that was the official designation by the World Health Organization. And moving on to the next slide. The origin of this virus is very interesting. Just to remind you, it's in the Coronaviridae family, and it's a single-stranded RNA virus. And these coronaviruses have a very broad range in animals, and particularly mammals, and in avian species. So there are a number that affect chicken flocks, for example. It's a very important veterinary pathogen when you look at the whole coronavirus family. We also have over 1,200 types of viruses affecting the various Asian or various bat families. And we know that the MERS coronavirus, the Middle Eastern respiratory syndrome virus, came from some Middle Eastern bat populations, and then to an intermediary with camels, and then into humans. The civet cat was considered the intermediary animal host as a mammal, again, originating from Asian bats. And it is speculated, based on the genetic sequencing that's been done, that this particular virus also has its origins in an Asian bat population. There's some speculation based on only limited sequencing that's been done, the DNA, the RNA fingerprinting, to suggest it may be an Asian anteater, the pangolin, but that's far from certain. And over on the other side of the slide, you can see the pictures that were done under an electron microscope to show you the virus. The corona is, of course, the crown, and this is the spike protein, and that's where the name comes from. And remember that about 1/3 of the human common cold is caused by this coronavirus. Moving on to the next slide. Just to remind you that, as I mentioned, the common cold we know about, but these other cousins of the human coronavirus, of which there are many, the SARS coronavirus 1 and SARS coronavirus 2, are much more serious. They're more virulent. They cause greater degree of disease. And that's what we're seeing now with the first outbreak in 2002 and 2003. We know that Hong Kong, Vietnam, and actually Toronto, an area, were quite severely affected with SARS coronavirus 1. We know that with SARS coronavirus 2, it has a much greater degree of communicability. We don't quite understand that. There are a few potential reasons. One is that this virus, the SARS coronavirus 2, has a much higher binding affinity. It latches on to receptors in the respiratory lining cells, so in the nose, in the back of the sinuses, in the back of the throat, and it latches on much more readily than with SARS coronavirus 1 or with compared to other human coronaviruses. And so that might explain. The other thing that we're seeing is that we see a very significant ramp up of the viral titers very early on in the disease, compared to SARS coronavirus 1, where it would take many, many days to be able to build up very high and significant amounts of virus. The good news is that it does not appear to be mutating significantly. The bad news is that in the entire world, there is no one who has any immunity to SARS coronavirus 2. So we have a very wide open, susceptible population. So you've got something that's relatively contagious. You've got a virus that seems to bind relatively quickly to the lining cells in the respiratory tree. And we also have the ability of it to bind readily. Next slide. Just to talk about transmission routes, the vast majority of the transmission, and this was shown in the WHO China Joint Commission report that was led by a Canadian, and it's been replicated in many other countries now globally. The highest amount of spread occurs in the family setting. So if you've got a family member and you're living in close quarters we're going to see transmission. And anywhere from, you know, up to 1 in 5 individuals to as low as 1 in 10, 1 in 15, depending on the circumstances. It's predominantly spread by droplet, and you can see someone coughing, sneezing, and those large droplets that come out. And then you've got also spread via contact. This can be direct contact from hands or through fomites. And we know that the virus can live for several hours to days, particularly if it's in material such as body fluids, spittle or sputum or other things. And then you can pick it up from this direct contact. It does not appear to be airborne. There are some individuals suggesting that it is spread in the air, but it does not appear to fit with classic respiratory viruses or other types of airborne pathogens, despite what you may see on social media. Next slide. This is just to show you how SARS coronavirus 2 compares to other viruses. So this is the reproduction number. The reproduction number is the average number of individuals that can be infected by a single case. So when you look at something like measles, you can see that the reproduction number is in the range of 15, and some of you will know who are older that measles spreads quite readily. Chickenpox spreads very readily. It's a reproduction number of close to 10. And there in the area down around 2 to 3, you can see where many of the respiratory viruses, including SARS coronavirus 1, the swine influenza, the H1N1, the common cold viruses, they all fit into this area. Most of the studies that have been done, including in Lombardy, there was a recent Harvard paper suggesting that it's in the similar range of 2.2 to 2.7. In Korea and Italy, where they had a lot of spread, it was in the range of 2.6. So right in the middle of where the classic respiratory viruses are seen. Next slide. And just to wrap up on my last slide, the incubation period is generally between 2 and 14 days. The median is about 5 days. And generally speaking, about 98% would develop symptoms within the first 10 or 11 days. And of those who are diagnosed, about 80% will have relatively mild illness, like the flu-like illness. 15% will have more severe illness requiring medical care or hospitalization with oxygen therapy. 5% go on to intensive care and ventilation. And the mortality rate, once you enter into intensive care and need a ventilator, is not good. We've seen that rates are about 3% when you're in the range of 60 to 69. That jumps up to about 8%, 70 to 79, and then above 80, anywhere from 12 to 15%. And this is what you saw, the tragedy unfolding on television in Lombardy. They have a very elderly population, and they were seeing very significant mortality. And also what we've seen devastating our nursing home and long-term care settings throughout Canada, which has really been devastating to be able to see. So we know that individuals who are older, and we know that individuals with a number of comorbid conditions do not fare quite as well. So in summary, before passing on to my colleague, Dr. Ghali, we have a relatively new virus. It's quite contagious, particularly early on, and it's spread through close contact with droplet transmission and through a direct contact. So with that, I'll move it on to the next slide, and Dr. Ghali will take over. Thank you.
All right, thank you, John, for the opening presentation. I'll just open and say that it's a real honor to present between both Dr. John Connolly and Dr. Verna Hu, because the two of them have been a big part of Alberta's response to COVID-19. John has been educating countless physicians on the virus, treatment approaches, epidemiology, and then Verna has led our health system response. I'm going to be talking about the epidemiology of COVID-19, and many of you in this realm have heard about this notion of flattening the curve. The flattening the curve concept relates to population-based measures that can be taken to reduce spread of the virus. And when we do that successfully, that can lead to a reduction in the number of people who are infected on the one hand, and then also lead to a spreading out of the infections over time so that the healthcare system capacity is not overwhelmed. And in talking about social distancing measures in the population, those are things that flatten the curve. And then healthcare system changes that you'll be hearing about from Verna affect the horizontal dotted line and perhaps shift that dotted line upward a little bit to change health system capacity to deal with COVID. And you'll hear a little bit about the things that have happened provincially on both of these fronts. Next slide, please. Now, as we go to the next slide, many people want to know about the state of the pandemic and where we are in the pandemic. And this slide is a busy visual of something called the dashboard. It's actually the Johns Hopkins COVID-19 resource map and resource center that gives information on what is very definitely a global pandemic. Key things to highlight on this particular slide are that as of last night anyways, there were over 4.2 million cases worldwide. That's a number at the top left. 291,000 deaths due to COVID recorded in 187 countries, and there are only 196 countries in the world. My guess is that even the 9 countries that haven't reported cases may be countries where health information systems are not capturing disease. This is a disease that has gone all over the world, and it does meet the official WHO designation or definition of a pandemic. Now, in this context, everybody wants to know, how high will these numbers go? How long will this COVID epidemic be playing out, and what's going to happen next? And that's because this affects our daily lives tremendously. Next slide, please. So to gain insights, I thought I would share with you some of the information that we have from other countries. So this first slide is the epidemic as it has played out in Germany. And the plot is time on the x-axis and numbers of new cases per day on the y-axis. And interestingly, what this shows is that the epidemic in Germany began with a big uptick of cases around March 1st. It peaked around April 1st. And then now we're into the middle of May, and you can see that we're now on the tail of the epidemic where there are relatively small numbers of cases, about 500 cases a day in a country of 80 million people. And then I just want to tell you that this means that in Germany, where there were 170,000 cases, there's only 0.2% of the population that is infected. 99.8% are not infected. Next slide. Italy is a country where we know that the epidemic was perhaps worse than it has been in much of the world. And here, just again, the timelines, the cases started to accumulate in an accelerated way approximately February 20th. The peak was about March 21st or so. And then now in mid-May, we're down to relatively low numbers of cases per day and relaxing interventions. Population of 60 million in Italy, about 220,000 cases. So this is about 0.35% of the population. So 99.6% of the population in Italy do not have COVID. Next slide. And then if we look at Canada, we're behind the European timeline. The first cases started appearing in substantial numbers approximately March 12th or 13th. And our peak appears to have been, it's a little messier because there were changes in testing criteria, but the peak appeared to be at about April 15th, 16th. And then you can see that the trends do suggest that we're beginning a decline, and we would predict this given what we've seen in other countries. There is a modeling analysis done by an international group in Singapore that has suggested that Canada may experience 97% of its cases by May 22nd. So just giving you a little bit of a perspective of how this might play out. Next slide. And then if we come closer to home, it's a slightly different format, but these are data generated by the Ministry of Health. You see, again, a timeline that mirrors the timeline of the rest of Canada, and certainly a suggestion, very encouraging numbers, as Dr. Dina Hinshaw has indicated in her recent briefings, consistently under 100 new cases per day, despite maintaining a very active testing program in the province. Next slide. So now I'm just going to shift a little bit into the mode of a proud dad, because I am the Vice President Research of the University of Calgary, and I want to showcase some of the nice work that colleagues are doing here at the University of Calgary. So this first screenshot is from a website that I can direct you to. The URL is at the bottom, chi-csm.ca. This is a web resource created by the Center for Health Informatics under the leadership of Dr. Tyler Williamson, one of our superstars here at the University of Calgary. And Tyler and team have generated a very interactive repository of information that is being used by people across Canada and indeed internationally to track the pandemic. Next slide. And then this is just one view of an interactive portion of this web repository of information that shows Alberta in the lower curve that cuts in underneath the curve for the rest of Canada. And this is just another way of looking at the same data that I showed you in those frequency curves previously. And there clearly is a leveling off of the case counts and an encouraging finding. And when you visit this website, you can look at other countries of the world and learn about this epidemic. Next slide. Dr. Williamson's work has been part of the work undertaken by a University of Calgary COVID analytics group that has done really impressive work that is informing governments at all levels here in the city of Calgary, the provincial government, and federally. And the activities of the work involve the surveillance work led by Dr. Tyler Williamson, as mentioned, some work on taking an inventory of social distancing measures that are in place around the world. And this is work led by Dr. Nishan Sharma in the W21C Research Center, part of the O'Brien Institute for Public Health. And then also some work on economic impact of the various social distancing measures and also economic impact of COVID. And I'll just put in a plug for an idea exchange coming up later this month, also hosted by President Macaulay, focusing in more depth on the economic recovery after COVID. And it's the combination of these three areas of study and how the three are interrelated that has given very useful information for data and evidence-informed pandemic planning. Again, this is an example of a research university contributing to policy and ultimately better health and better lives. Next slide. And this is the last slide. This just reiterates a couple of points that President Macaulay raised. We have had a very robust research response here at the University of Calgary. We are one of Canada's leading research universities, and we have over 80 research projects that are tackling COVID. We have competed nationally and internationally and secured almost $5 million of peer-reviewed funding for COVID-19 research. This involves over 150 PIs in our university and a number of their students and staff. And then just two highlights. One is the data analytics work led by Tyler Williamson that I mentioned. And then also I'll mention just a very exciting development. Dr. Dylan Pillai has recently completed, and there was news coverage on this, work on a 30-minute test. So a test completed in 30 minutes for COVID, and this will advance our ability to detect COVID remarkably. So with that, I'm turning it over to Dr. Verna Hu. And the only thing I'll say is that I am a physician in the healthcare system. And when I did my recent shifts at Foothills Hospital, I was so proud of what Alberta Health Services has done to be ready for this pandemic. And I'm so delighted that Verna is here to share what AHS has done. Thank you. Over to you, Verna.
Great, thanks very much, Bill. And it's a privilege to be invited. And just to say that I'm feeling a little bit left out that I'm not from the University of Calgary, but after saying that, the best thing about leading a provincialized organization is that I do get to work with people from all over the province. The first slide I want to share with you is just as a reminder of actually what's happened and where did Alberta Health Services start working around the COVID. And since it was announced last year that COVID was starting to spread, we actually had started pretty intense work starting in December. So this wasn't something that we started with our first case. In fact, we started doing a lot of planning, both within the lab as well as procuring supplies back in December and January. And in fact, we set up our emergency disaster management system starting in January, which is about 2 months before the first case was identified. And the reason for that was that we knew that we had to have an organized, integrated provincial response through the public health teams. And setting up this provincial emergency operations center was really critical to the coordination. And since we've actually set that up, just to give you a sense of the immense amount of work, we've developed about 1,200 documents that provides guidance and recommendations to not just within our organization, but to the general public. You can see here that the first case came out on March the 5th. And in fact, we actually started planning for what we call testing centers to do the swabbing. Actually, that first week, we knew that the first case was going to be imminent. And so we knew that we had to start setting up assessment centers. And of course, we set it up in the 2 big urban centers first, and then very closely followed it with the rural settings. Just the other dates along that was important for our perspective was that, as you can see here, the Public Health Emergency Act was declared March 17th. And that was the day that we actually started postponing surgeries. We knew that in order for us to try to manage capacity and to build capacity and block beds for potential COVID patients, we had to find that in the system. And the only way that we could do that was to actually start postponing procedures. And we know that was really hard for Albertans. We also had to start postponing ambulatory clinics, but we had to find the space, we had to find the staff that we knew we needed to work in the system. And so that was the type of work that we actually did in March. So March was an incredibly, really busy month for us to make sure that we had all the supplies we needed, to make sure that we had the testing in place, the swabs in place, to make sure we had the people in place. And then, in April was when we started hearing a bunch of outbreaks. And the good news is that the curve, as Bill has said, has flattened. And so now we're looking at relaunch. We started opening up day surgeries last week. And this week, we're actually opening up ambulatory clinics. Next slide, please. So what I wanted to chat about a bit is about testing, because there are sort of a few areas that I like to highlight about where we've really excelled. And as Bill had mentioned, one of them is actually the testing rate. So if you look at us and how we perform in terms of per capita testing for COVID, you can see here that we're above every other jurisdiction, and obviously the top in Canada. And part of it is because Alberta Precision Laboratories, who is a wholly owned subsidiary for Alberta Health Services, is really well integrated into our system. And I think more than anything, the criticality of the lab system has really been highlighted during this COVID pandemic. And so we started off, can you imagine, we started off with about 30 tests a day. The lab actually had to develop their own recipes to test for COVID. There wasn't any kit that you can actually purchase because, COVID was just newly discovered at that time. So the lab team actually had to develop a recipe to test for COVID, and they did that in January. And we shared that across Canada. When we started testing, we started off with about 30 tests a day. We went up to 300 by the weekend. So within a 24 to 48 hours, and now we're up to a testing capacity of about 7,000, targeting about up to 16,000 per day by June. And the reason why we're able to do that is that we're able to redeploy staff. We're able to make nimble decisions around making sure that we just test for influenza and COVID. But very importantly, I also want to talk about how do we actually get the tests to the lab in order for it to be done. So for example, we actually had to increase our HealthLink which is a telephone system, as you know, that provides 24/7 nursing advice. And last year, our average intake for calls were about 1,900 a day. During the COVID in March, we were fielding up to 7,000 calls a day. And so very quickly, we decided we need to do an online platform. We were the first to do that. We share that with every other province in the country, as well as actually other parts of the world for this online assessment tool. And then once we did that, we then had to get it to the swabbing, right? We had to actually do the swabs at assessment centers. And so very quickly, as I mentioned, we started mobilizing that on March 7th. We've now got 42 across the province. You obviously have to ship it to the lab. And of course, all the supplies and reagents. I've learned more about labs, supplies, and reagents than I really want to know. But this actually includes innovations within Alberta companies, because for a while there, we couldn't get enough swabs. Every part of the globe was running out of swabs. And so we've worked with 3D companies and printing companies to develop swabs, and medium and plastic companies to develop the types of things that we needed to put the media in. Next slide. So moving then from testing and lab over to protective personal equipment, there's been a lot in the media about this, about the fact that, why does Alberta have supplies so readily available, whereas every other jurisdiction across the globe is complaining about not having enough PPE. And I have to say it's because of the fact that we have an integrated system within the province for procurement. So we have a bulk purchasing power in Alberta. AHS has been developing relationships with big companies over the last 10 years. And we've got very good relationships with people so that we actually are able to know who are good companies to order from. And we've actually also got a good reputation for that. So I'll just give you an example of what it takes to make sure that you get the right supplies. A lot of our supplies comes from China. And for example, we actually have a team in China who actually inspects the supplies that we get. We've got a warehouse in China that actually can store the supplies. They actually videotape the quality of the purchases. Obviously, they have to fill the standards that we expect, that we get a videotape real time that's sent to us before they're actually placed into a chartered plane that we charter to actually bring them over to Calgary and Edmonton airports. That just gives you a sense of the detailed amount of work that our procurement team led by Jitendra Prasad does every day. I mean, it is quite amazing. And our burn rates for PPE is actually unbelievable. And I'll just use procedural masks as an example. You can see here that before COVID, we're using about 30,000 procedural masks a day. Right now, we are using over 750,000 procedural masks a day. And so we're ordering like millions of procedural masks. You've heard a lot about N95 respirators. Again, the orders that we've been purchasing is about, in the millions. And that's the reason why we've actually been able to provide PPE to other parts of the province, to non-AHS facilities, as well as to other parts of the country. Next slide actually just shows you, Bill had showed you the modeling and the flattening of the curve. And, someone once said to me that all models are wrong, but some may be useful. And so you can see here what we wanted to do is that we didn't want to actually fulfill any of the scenarios that were placed on here. Because at the end of the day, all the sacrifices that you have been making, in fact, has been in an effort to help the health system cope with what we know is coming in terms of the COVID hospitalizations. But you can see here that we've got the 3 scenarios where the peak is actually supposed to be happening between now and next week. And you can see the bottom one, which is actually our actual curve. It's really, really flat. I'm not sure that we'll get much of a peak. And because of that, we're able to relaunch surgeries last week. We did about 1,000. Target is 2,000 this week. And we actually are launching ambulatory clinics to get us back up to doing the things that we need to do. Next slide goes into the innovations and partnerships. And at the end of the day, despite all the difficulties we've had with COVID and all the lives that have been lost and the difficulties for all the people that we know in the province, there actually has been some silver linings and maybe bronze linings, and that's around the innovations and partnerships. And I just want to highlight some that are very, very specific to the city of Calgary. I just want to say thank you so much to the sprung structures. If you go outside of Peter Lougheed right now, we managed to build that sprung structures along with other partners within 17 days. And now we have an ability to actually decant some of our emergency room activity. We know emergency is really cramped in that site, and it's really quite amazing. It can be made into a field hospital if we need it, but it is going to be really flexible for us. As I mentioned, we've been working with the University of Calgary as well as some other companies in Calgary around ventilators to be developed, and we hear it's imminent that we're going to be receiving a generous donation of ventilators, and so we're really excited about that work. But again, it wouldn't have happened without the partnership in Calgary. Other things around the province, we've been really trying to mobilize local companies and local industries. So for example, there's an Edmonton company that we contracted to sew us scrubs. So these are the greens that people wear every day in our facilities. And we contracted one company to make 1,000 scrubs for us. We want them to go up to 10,000. And they are so grateful because they're able to keep people employed at the time when our unemployment rate is so high. I can't say enough to the Cummings School of Medicine around the medical students. They're absolutely critical for us as we are trying to do more contact tracing, and they're continuing to do some work for us. And a development program, again, through the Cummings School of Medicine. A lot of the educational things that are around COVID are being spread to all of our teams. And then the Calgary Health Trust, they recently gave us a donation of $1.7 million to actually purchase more lab equipment so that we can actually do more testing. And these are just a few examples of the innovations and partnerships out of Calgary. And for that, we are so grateful as Albertans. And just on the last note, again, I don't have a Calgary Flames jersey, but I do have allergies. And anyway, I'm going to pass it back to Ed at this point.
Thanks, Verna. Really, really appreciate it. And as Bill and Verna and John join us on screen, I'd like to open the floor now to questions from the audience. And you can send your questions through the chat function at the bottom of the screen. And many questions have already come through. So thank you very, very much. What I'd like to do is to maybe ask John, in your opening comments, you mentioned the many viruses that we're subject to. Why are some viruses more dangerous than others? And a question that's on a lot of people's minds right now are, if you have been infected and recover from COVID-19, can you get it again, or actually are you immune? So John, maybe you could begin.
That's a great question. I'll try to address the latter part of the question first. The WHO has said there's no passport for immunity, but as studies are accumulating, it does appear that with the ability to be able to build antibodies up, which occurs in most people around day 7 to 10, that those antibodies contain some what we call neutralizing antibodies, which means that you will recover. And given that we don't have a lot of evidence to support that the virus is mutating quite readily, similar to influenza, it does appear that there will be some long-lasting immunity occurring with this. Those studies are not complete yet at this point in time, but it's looking good at this point. With respect to why is this virus more dangerous than others, it appears to have some virulence properties. So when you look at the common cold virus, if you recall, it's co-developed with mankind over tens of thousands of years, and we're able to have some pre-existing immunity to it. We've adapted somehow in a co-evolutionary perspective. But with this one, it's migrated immediately from the setting of the bat population, made the jump into the humans. There's no immunity. There's been no co-evolution whatsoever. So in many respects, this is a One Health issue as well, which I know the University of Calgary has done a lot of work on. So what's happened is we've seen a relatively highly virulent virus enter the human population with a relative degree of communicability, and it's spread across the globe in a very highly susceptible population. And as a result, that's where we are today in that respect.
Thanks, John. And maybe I'll just add a question on top of that one and then open it up a little bit more. I know that in the press, there's been a lot of comparisons between what we're experiencing with COVID-19 and what we experienced historically with the Spanish flu. Can we look at the spread of the Spanish flu to predict how the coronavirus in particular will behave? And maybe John or Bill, you can start off, and Verna.
Yeah, I'll start with that one. You know, with my background in infectious diseases epidemiology, the answer would be there are some parallels. There are also some settings in which we do not see those parallels. So, for example, where we do not see it is in the mortality. The mortality with the Spanish flu was approximately 0.2%. We're seeing something that's tenfold higher if you look at the average mortality of 2%, although that's difficult to ascertain with certainty because we don't know how much of the population in the denominator might have been affected. We only know that we've tested. But certainly when you look at the mortality in certain groups, elderly and those that are with other conditions, it's higher. So that's one thing that does not appear to be similar. Where we do see some similarities is in the public health measures, you know, the social distancing, and some of those other measures that have been done, you know, large gatherings are being prohibited. Those were readily employed. And we also saw a second wave occurring with 1918 influenza. So there are many parallels, and many people are digging through the history books to see how we might be able to use that information. And I think Professor Galley also commented on some of that.
Bill?
Yeah, so just to pick up on some of John's comments, I was going to say that the playbook from 1918 was actually very well documented on social distancing measures that were helpful. And there are some interesting learnings on quick reopening of schools, where there was a fascinating comparison in 1918 of Philadelphia and St. Louis. St. Louis kept schools closed and prevented a second bounce in the curve back in 1918, whereas a much quicker reopening occurred. And so there are learnings like that. The one caution would be to say that influenza viruses are different than coronaviruses. And so sometimes you'll hear people saying, oh, well, when the second wave comes, oh, that definite second wave. I think that there are experts saying that it's not a given that there will be a second wave, particularly if social distancing measures are weaned off in the proper pacing and with careful surveillance to prevent any little upticks. So we can potentially avoid that second wave.
Can I pile on that question and bring Verna in? Because you mentioned this different experiments have done historically in terms of opening or closing. And I think there's sort of this tension between reopening and maintaining isolation from an AHS perspective. Verna, would you like to comment on how we're trying to deal with that tension?
Yeah. So there's obviously there's different camps of thought in this, and I think what we've been doing is, I think we've been fairly strategic around what we've been doing around the relaunch. We're doing it phased out, so it's not all in, because as everyone knows, if we undo everything that we did starting 2 months ago, then we are going to get a second wave and we're going to be back to square one again. And so we don't want to lose what we've managed to do. And so there's got to be a certain amount of discipline to that. So the things around hygiene, washing your hands often, avoid touching your face, disinfect frequently touch surfaces, you know, cover your cough and sneezes, stay home when you're sick. Those things will have to continue. And so that's not going to go away anytime soon. And I think how people are going to relaunch and open their businesses, I know that guidelines have been put out through the Alberta government over different types of practices and different businesses. And so again, I think we are going to have to be fairly disciplined over the next while. So, you know, yes, we'll be able to do some things that we weren't able to do, you know, a month ago, but it's not going to be completely the same as it was pre-COVID. And I think we're going to have to be a little bit disciplined about that. And it's hard to be patient because we've been through a lot, but at the same time, I think we need to make sure that we don't lose the momentum that we built out over the past 2 months.
One of the additional questions from the audience builds on that, Verna. So I'll just bring it in here. have there been any policies or new practices that have been implemented in preparation and response to COVID that you think might be adopted permanently? I mean, you mentioned earlier the importance of lab services.
Yeah, so I mean, there are some definitely things that we've been doing differently that we were going to anyway, but the pandemic's actually pushed us to be much faster. So an example is virtual care. We've reduced our ambulatory clinics probably about 60% across the province. But what we've noticed is that the 40% that we're doing right now, more than half of them are done virtually. Patients are happier. The healthcare providers are very content with it. And so much so that we're not going to go back to the old days. I mean, I think at the end of the day, if we're able to provide care in the home setting and patients' outcomes remains as good or better, you know, why would we go back to the old way? So I think there are some practices where we are going to make fundamental changes because it is for the betterment for Albertans.
Great, thank you. One of the questions that's come up in Verna, you showed some just remarkable data in terms of what Alberta has accomplished. There seems to be, and whether it's true or not, Calgary seems to have many more cases. Is there something actually behind that? And that'll open up to Verna, Bill, and John.
Yeah, I don't know if Bill would have a sense. I mean, I've got my own gestalt about that, but for sure we had, you know, a relatively smaller outbreak early on in Calgary that kind of set the tone early on. And the other thing is that I think Calgary also has more international travel. It's a little bit bigger population. And there's a lot of also interconnectedness between Calgary and some of the other smaller jurisdictions, much more so than perhaps Edmonton is. But those are things that I'm thinking about. I'm sure John and Bill has some other comments.
John? John, you're muted.
Okay, I'm unmuted. No, I agree. There are some fundamental differences. There have been other studies that have shown that the proximity to major international airports, remember Calgary's got the longest runway in the world. They've opened a lot of flights to Asia. It's also one of the most Americanized of all cities in Canada. So there was a lot of people returning from the United States, which was a major vector for transmissibility. If you look at British Columbia and even Alberta, that two-way traffic between the United States and Canada was the international airport, and then also the industries that are present within Calgary and the connectivity between the outbreak, the largest, you know, in North America in the meat processing plant, where there have been many outbreaks now for the US and across the world, multi-generational families that were living together and tied in with where spouses were working in the nursing homes as well. So it's all interconnected. And if you look at the epidemiology of it, there are very good explanations, very rational and scientific explanations as to why Calgary had that higher rates of transmission than we saw in Edmonton. And there are other factors as well, but those are some of the major drivers. So I tend to agree with what Verna stated, but I would emphasize very strongly those are absolute factors over.
Bill, anything to add?
Yeah, I just, it was an excellent question. So the audience member who asked about, will there be anything in the new normal that we learn from this pandemic? And a couple of observations I would make is, number one, I wonder if we will do away with the handshake. It's a human gesture. It's something that we do, but there's no question that it is a vehicle for transmission of colds, and colds aren't fun, and the flu. The second thing to say is that influenza, where COVID has had so much news coverage. Every year, even last year was a mild influenza season, flu season. There were 49 million cases of confirmed influenza around the world and about 70,000 deaths. So that's pretty remarkable. And I think some of what we're learning around social distancing could be adopted going forward. And long-term care facilities are, we know, the domain that has been really tragic here in Canada and around the world around COVID. And we need to adopt infection control measures there and learn from what's happened.
Maybe I can follow up because lots of questions in the chat box related to, I mean, you talked about the power of social distancing and how that has helped to flatten the curve. A lot of the questions in the chat box are asking questions about whether masks are effective and efficient in reducing transmission, and any comments on the use of masks as part of the flattening the curves.
Maybe I'll just start on it, and then the first thing to say is there's a different discussion when we talk about masks in the hospital setting, where we know we're dealing with infected patients, and there are the two kinds of masks, N95s that are used in special circumstances in the hospital, and then we're regular surgical masks. But in the community, it is a bit of a controversial topic because it has not been definitively proven to be helpful in reducing the risk of getting an infection when you go to a grocery store. However, it is still a public health recommendation to wear a mask if you're in a situation where you're going to be in tight quarters. So if you're going into a situation where you can't be more than 2 meters apart from people, it's not incorrect to use a mask. You need to be careful with your hands around your face. That's one thing. And you need to be careful if the mask gets soggy, and it may actually do more harm than good. So that would kind of be the bottom line. It's not wrong for those people who are out at Costco wearing a mask. It's not wrong to be wearing one, especially if people feel more comfortable with it.
Verna, did you want to add anything?
No, I totally agree with what Bill is saying. I think at the end of the day, everyone was going to be looking at wearing masks in areas where you actually can't control sort of the space and the environment piece. And remember, when you wear masks, it's not so much to protect yourself, but to protect others. And so that's the whole purpose, I would say, of wearing masks. And there are different grades of masks too, right? So masks that you wear in the public are going to be very different than the types of masks that we would wear in a hospital setting. So,
John, you're on mute.
Yeah, no, I just want to comment that the type of mask is very important. There's an extensive engineering of textiles and science into this. And it's quite clear that masks that are made of cotton are absolutely inferior. And so the recommendations are going to have to come out and look at spun-bond polypropylene, which is widely available. It's in diapers, and it's in almost all of the surgical medical masks that we use. And the WHO is looking currently at recommendations for this. So if there is a mask policy, it's got to have some science based on the components of the mask that are going to be used, because some of the studies, as Dr. Ghaly has mentioned, some cotton masks become saturated, they become virtual virus factories. And so the public health recommendations that are going to come out need to be steeped in evidence, and they need to be steeped in science. And I'm hoping that we can provide some of that science and evidence for whatever recommendation comes out in Alberta or in Canada. Currently in the EU, there are many recommendations for homemade masks, and they do contain higher filtration capacities than what we're hearing about with cotton masks. I hope Canada and I hope Alberta follows suit and looks at this science and evidence in its proposals as we move forward. And as Verna says, we need to look at it as a bundle of things that can be used in that respect as well.
So John, maybe keep your mic on, because this question I think will be the next question. And I only have time for 2 questions. I think there's probably about 800 questions in the queue. But one question I think that on people's minds are, how realistic is it to expect an effective vaccine, since no vaccine has been developed for SARS or MERS, ? And have vaccines been successful against any coronaviruses? And John, maybe you could start with that.
The short answer is, to my knowledge, I've not seen anything even in the mammalian or avian world for effective coronavirus vaccines. There is a great deal of work going on. There's a very unfortunate misstep, because there was a lot of funding that went into SARS coronavirus 1 vaccine development. It got cut off about 3 years after, because everybody said we're never going to see this again, and it's gone now. And now they're moving very quickly. Hopefully within a year. There are some good trials going in Oxford in England. They've already begun some phase 1 trials with the vaccine. So I think given the impetus around the world, we will see some vaccine development, but unfortunately, it takes time. We have seen a success with the Canadian flavor to it with the Ebola vaccine. So I believe that we'll get there. It's going to take time.
Great, thanks. And the last question, Verna, maybe you could handle this one. Considering all the experiences we have had, including with physicians, now with working from home and use of digital tools to communicate, do you see this as part of being a permanent move to more use and availability of telehealth options or remote options? And that obviously is impacting all of the things that we do in life.
Yeah. So absolutely, we're, even before COVID, for example, last year we did more than 48,000 telehealth sessions in the province and helped Albertans avoid 11 million kilometers of travel. I know I'm throwing a lot of data at you, but we live by data, right? And so yeah, absolutely. We started licensing for Zoom as an example, knowing that we're going to have to provide a platform. And, we did more than 1 million hours of Zoom within like 2 or 3 weeks. So, obviously the whole organization is consuming this very avidly about that. The other thing that I think around the virtual care that I'm really excited about is that we are going to be sort of moving on more remote monitoring for our virtual hospitals. We've got 2 virtual hospitals, one in Edmonton and one in Calgary. And we're going to be able to remote monitor probably 600 to 700 Albertans in the province through this new platform. And that's like a hospital. So that means that we're going to be able to look after Albertans in their community through these remote monitoring and at-home healthcare teams. It's going to be as though you're admitted into a hospital, but you're at home. I mean, the convenience and obviously the care will be what Albertans want. And so we're really excited about some of these initiatives that we are going to build on because it's the right thing to do.
Great, thanks, Vernon. And that answers another question was in the queue about how AHS is handling the rural and more remote communities at this time. So thank you so much. Unfortunately, we're coming to the end of our time. The questions in the queue are just, it's a very, very, very long list. And I'm sorry we couldn't get to all of them. I just want to thank John and Bill and Verna for sharing your knowledge with all of us today. And thank you to our audience for all the great questions. As I said, we only got to the tip of the iceberg and some really, really important questions about the phenomenal role that AHS and other universities have done in the province to try to, as Bill talked about, in terms of flattening the curve. We are always striving to build the best possible experience for our community. So please let us know how this webinar went. And you'll see a short survey in your inbox tomorrow for those that are actually registered. So to learn more and also to get involved, please check out these resources we have listed on the slide. The support for students in COVID-19 research at UCalgary, the news, podcasts, and webinars from UCalgary experts that you can see on ucalgary.ca, COVID-19 support. Lots of material there, lots of information there to help us through this time. And also something that I'm really, really proud of what our students have done and others to explore provincial volunteer opportunities. Please connect to volunteerconnect.org. There are just some inspiring work that's being done by our students and by our community. Our next idea exchange is set for May 26th, when we'll look at the economic impact of COVID-19. So I want to thank everybody again for joining us today, and I hope you can join us for the next event. And until then, please, please take care of yourselves and your families. Thank you.